Good afternoon, everyone, and welcome to this webinar, which is the second of our evidence sessions as part of the NHS Productivity Commission. The first session was about how we can learn from other countries, and the third session will be about what good practice we can learn from in the NHS. And today's session is focused on what can we learn from other sectors. I'm very excited to have Charlie Mayfield and Bart van Ark, whom I'll introduce in a little bit more detail a little later on as our speakers today. And I'm also very excited to have what I hope will be a wide-ranging and interesting discussion. So very much encourage questions from the audience. There should be a Q&A function on the webinar app that you can use to send in your questions, and we will collate them, and I will be asking them to Charlie and Bart a little bit later on. Today's session is part of the NHS Productivity Commission's overall evidence gathering process. And the question we've set ourselves to answer is how can we collectively come up with system level solutions for the NHS to become more productive in a way that's not just one-off, but can sustainably improve its productivity over time. And I don't think anybody would disagree that there's an imperative to become more productive, given that the demographic headwinds are very significant, and there will always be a budget constraint. So the more we can get out of all of the resources that we put into the NHS in terms of better outcomes for patients and better outcomes for citizens, the better. But that's, of course, an incredibly tough challenge that we set ourselves. But it's not a challenge that's unique to the NHS. So the private sector, as you will know, has also really suffered from a productivity stagnation in the UK. There are many reasons for that, but there are also some bright spots in the private sector. There are many businesses, there are many sectors, there are many parts of the country where productivity has in fact increased significantly. So part of today's session will be about learning lessons from those other parts of the economy, other sectors. And then we'll also be coming into the discussion in the Q&A around how might these apply to the NHS. Just to give you a quick idea about the format, I will ask Bart and then Charlie to give us some opening remarks, and we'll then have a quick sort of follow-up set of questions. But we'll then open it up for Q&A from the audience. So please send through your questions, and I'll be seeing them hopefully on my iPhone here, and we can have a really rich conversation about both what those lessons from other sectors are, but also how they might apply or not apply to the NHS setting. And just to also mention that the session is being recorded and the recording will be available afterwards. So let me then get into a quick intro about Bart and Charlie, who are both incredibly well qualified, I think, to be speaking to us today. So Bart van Ark is the Managing Director of the Productivity Institute at the Alliance Manchester Business School. And in addition to overseeing a huge program of research around productivity and what drives it, what are some of the barriers and what are businesses doing to drive it, and what indeed government can do, Bart has a very broad engagement with businesses and with policy. So it's not just about the academic aspects of it, but also how that plays out in the real world, what we can learn from it, and very much look forward to hearing what Bart's observations are on these kind of broad questions. And then Charlie Mayfield, who currently co-chairs the Keep Britain Working initiative. So very busy trying to get people back to work or keeping them in work, which is obviously incredibly important for the broader economic prosperity of the country, and does have some touch points with the NHS. But previously chair of John Lewis Partnership, so lots of experience in corporate leadership around how to run a business, which is always more challenging than people in the public sector think. They think, oh, productivity, all this stuff, it's easy in the private sector. Well, I can tell you it's not easy. It is challenging, and I think Charlie is one of the best people I know to explain how you work through those challenges. And of course, Charlie is the founder of a charity called Be the Business, the whole purpose of which is to help businesses improve their productivity. So we're in for a real treat in terms of perspectives from outside of the NHS, from the broader economy, which also faces productivity challenges. So with that intro, I just want to turn to Bart and see what thoughts you have around what we can learn about productivity in the rest of the economy.
Right. Thanks, Tira, and good afternoon, everyone. And thanks for the invitation, and also congratulations with starting this NHS Productivity Commission. I read the diagnostic report again last night, and it's really, when you read it through, such an incredibly important topic. And I think you're hitting at the right issues there. The question today is there anything to learn from the private sector or the wider economy, which is sort of an underlying assumption that there probably is. And I think I would agree with that, although there are probably also quite a few differences that will come once we start discussing this. But taking the wider economy as a start, we have to realize that not only has the UK economy slowed down in terms of productivity growth over the last 2 decades or so, basically since the early 2000s, and definitely after the financial crisis. But actually, slowdown in productivity has been very widespread across the G20. Just for your information, of the G20 economies, the only economy that has actually accelerated productivity growth in the last 10 or 15 years is India, and everyone else has seen slowing productivity growth. So it's a bit of comfort there. You're not on your own, but at the same time, it also means what is the sort of systemic problem that they're beginning to look at. Of course, we all look at the US now, and we see a big acceleration in productivity there, and a lot of excitement that maybe our artificial intelligence is making a contribution, which it probably is. But we should realize there are other things for the US, notably the massive stimulus program under President Biden that is still working its way through the economy that is explaining some of this. So don't always look at the US as the North Star. The jury's still out on that. In the Netherlands, we always say, there's a lot of more water needs to flow through the Rhine before we see the impact downstream. And I think that's certainly true when it comes to artificial intelligence. Now, having said all that, the UK economy does have some specific challenges, and that is creating several what I would call productivity traps. And productivity traps are problematic because if you have sectors or regions or groups of individuals who actually been a long time in a very slow productivity mode, it's very difficult to get them out of it. It's not like a simple policy intervention is going to change something. You need to have systemic interventions. And we have seen some of these traps developing across the UK economy. So at the Productivity Institute, we identified sort of 3 main barriers we have to overcome in order to get these various regions, firms, sectors out of that trap. The first is that there has been a chronic, broad-based underinvestment in the UK economy for several decades now, right? If we really go back, and this is not just physical equipment or infrastructure, this goes into human capital, it goes into all sorts of other assets in our economy in which we have been underinvesting compared to other economies. And that is, of course, creating huge challenges in terms of the asset base, on the base of which you can begin to build productivity growth. And again, if we take that to the healthcare sector, of course, we have seen some of that in the healthcare sector as well, notably the structural underinvestment in capital in the NHS. That's sort of an issue that you can get over very quickly by making a quick investment in order to get out of that kind of trap. The second is that we are very good in creating new knowledge and new technology. We've got the best universities in the world, including my own in Manchester, but we're not very good in diffusing that technology across the economy. And that has to do with the fact that we have been struggling with building sufficient scale in terms of institutions that can diffuse technology and knowledge rapidly for the economy so that many more firms, except the best firms in the economy, can begin to perform better, which creates this huge tail of underperforming firms. And again, if we translate to the NHS, which is a huge system on its own, we again see, and it came out in the report when I read it last night, some very well-performing parts of the NHS sector in terms of productivity, and a long tail of parts of the system that are not doing very well. And the third big problem in the UK compared to other countries is that we have a really complicated governance structure in the UK. Which, on the one hand, we have this extremely centralized governance system with Whitehall and Westminster, where basically all the decisions to an amount of detail are taken that is sometimes frightening when you talk to ministers. And at the same time, the other hand, we got a very fragmented institutional framework in terms of devolved nations, combined authorities, local authorities, without a very clear structure around it. And that makes the governance of policy in order to improve productivity also complicated. So chronic underinvestment, lack of diffusion of technology, and a fragmented governance system are 3 specific UK problems that we're seeing. And again, we see all of those 3 translated, I think, in the NHS as well, which we can come back to. So that's very much about the barriers. The question is, what are we going to do about it? And I think Charlie and I will agree on one thing. We can talk about policy forever, but productivity is done by business. Sometimes I talk to business leaders and say, isn't productivity about government? And we say, no, productivity is actually business community who is actually doing this. So we spend a lot of time at the Productivity Institute on actually working with the business community, but not just with the business community, but also with the third sector, with the public sector, around thinking strategically around productivity. Again, productivity isn't an easy concept for businesses. Most businesses don't have that sort of as their North Star. It's better business performance or creating growth or creating more value for your customers. Productivity is, they all know it's important, but if you ask them, well, what is it really? They quite often don't get much further than, well, it's efficiency and cost saving. So say, well, yeah, sure, that's part of it, but there's a broader story here. So what we're trying to do, talking about strategic productivity, is to sort of widen that viewpoint of what productivity really is about. And we think there are sort of 5 critical elements that are driving the productivity of any type of organization. One is digital and innovation. So it's basically the technology part. The second is skills, as well as well-being of your workforce, that these things go very well together. People are only willing to train if they feel good about these skills being helpful in performing better at their jobs. The third is management and leadership. The fourth is communication, and in the private sector also marketing. That's perhaps a little bit less in the public sector, but basically collaboration, communication, and marketing is important. What is it we're actually doing for our customer? And finally, of course, it's about mobilizing finance. And we call this mobilizing finance because quite often we like to talk about we don't have the money. The issue quite often is that the money is there, but we're not spending the money in a very smart way. So mobilizing finance is a critical issue as well. And what's interesting about the sort of 5 key drivers is that none of them will actually make an organization productive in itself. All of them will be connected. You can't do digital technology unless you have a skilled and a motivated workforce. You need to allocate finance in order to concentrate your resources, and obviously you need to have very strong management and leadership around this as well. So I think I'd like perhaps today really sort of trying to make the argument that I think these 5 drivers, as we'll talk to the business community about, very much also apply to public sector organizations, including the NHS, but I'd certainly like to hear a little bit more about this. A lot of this is around collaboration. It really requires that different stakeholders in an organization align. Productivity isn't done by the CEO or by the CFO or by the chief operating officer. It's done by many different functions in the organization. But for that, you obviously need to have a crystal clear narrative around how do you think around that productivity and why this is more than just cost savings and efficiency. And then finally, and that's my last point for opening remarks, you need a bit of a theory of change. Productivity is always about the dynamics of an organization, moving you from one place to another to create better outcomes and to allocate your resources in a better way to create those outcomes. Productivity is always not just about outcomes, it's also about the resources you're going to put in and clearly combine them. That narrative is very important, and the theory of change is really around what do we prioritize? Because if you heard me just talk in the past 2-3 minutes, there's so much that needs to change when you want to make an organization more productive. So what are we going to do first? Where are we going to put the emphasis and so on? So prioritization, I think, is a critical element in the productivity journey. And for that, you need to have a fear of change and a narrative around how you want to get from here to there. And I hope that some of the strategic productivity drivers that I was introducing here help us along that way. So let me leave my introductory comments at that point and hope to pick up a few later during the discussion.
Thank you so much, Bart. Wonderfully rich discussion already, and no doubt also complementary what Jim was going to say. So, Charlie.
Thank you, Tara, and thank you for your very kind, probably overly generous introduction. Certainly for me, less so for Bart, but anyway, I feel it's good to be here because I think this is obviously a very important topic. What I think I should say though is that I don't know a lot about the NHS. And so I don't want to sort of pretend in anything I'm going to say that is anything other than the case. But I have been grappling with this challenge about productivity for quite a long time. And I think perhaps the first thing to say is that improving productivity is actually quite hard, but it is also very important. And therefore, the fact that we've found it difficult is a reason why we should really keep on trying and try differently and try in different ways. And I think therefore the work that you're doing is of real importance because it's an example of doing that. I think one of the other things that just came to my mind as I was just listening to Bart and Tara, and I'm conscious that I'm sitting between two economists of what I'm about to say. But
does it feel great?
But one of the things when we were in the early days of founding Be the Business, somebody that Tara certainly knows very well, somebody called Ian Davis, who we both worked with in a former life, said the thing about productivity is it's a deaf word used by economists. And so it's all, for many people, it has this appearance of being basically very reductive. And I think that actually does speak a bit to some of the challenges. And in fact, in the context of Be the Business, where what we're doing is we're talking about how you improve productivity, because we've learned from economists to say it's very, 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 very important, and they are right about that. When you're engaging a business community, particularly a small and mid-sized business community, quite often, actually, if you use the word productivity, it doesn't help you to get the conversation off on the right footing. If you talk about growth or competitiveness or getting better or improvement, you generally get more engagement. And there's probably something in there in the context of the NHS where there is obviously a productivity problem. I mean, just to sort of perhaps position what I'm going to say, we're seeing rising demand for all the reasons that we're well aware of, aging society and higher incidence of ill health, and also more demand from the growth in technology and the fact that that provides more therapeutic options. All adds up to increasing demand. More money is going into the system, but I think I'm right in saying on most measures, if you actually measure therefore the output against the money, we're not seeing that moving in the right direction. Whether it's flat or it's going down, I'm not sure, but you will obviously know. And I suppose, and that's obviously a big issue because these numbers are huge, and this really matters to society and to pretty much everybody in the country. So it's really, really important. I also think it's interesting to observe, and I always find this for talking to people who work in the NHS, is the intention of the people who work in the NHS. Now, people don't generally go to the NHS because their number one priority in life is to make a lot of money. It's actually, generally speaking, they go to the NHS because they really actually want to improve health outcomes and improve people's lives. That's why they're there. And so the intent is so strongly in the right place. The efficiency outcome obviously has some challenges. And of course, the complexity of human health and the mechanisms through which we then handle it is very high. It's just inherently complex. Every one of us is different. Every health condition we face is different. Every way we recover or don't recover from illness is different. And all the ways in which this is then delivered in multi-site operations in all sorts of different environments with different capabilities. This is inherently incredibly complicated, this whole territory. And also, the other thing that strikes me is there's huge amounts of system interdependability. So, so it seems to me that one of the challenges is you might try and improve the productivity here, but actually that doesn't necessarily achieve better outcomes unless you've actually managed to change the whole system. So it's quite difficult because it's quite hard to sort of, wouldn't it be great if we could just take it piece by piece and do it one at a time and then build it all up? But it doesn't quite work like that. So I'm telling you everything you already know, but I think it's worth just sort of giving a bit of airtime to the complexities that work here. And I suppose what I then hear about when I do talk to people within the NHS who've grappled with these issues is you often hear about management versus clinicians. It seems to be quite something that comes up quite frequently. And I suppose what I wonder about is whether what we're seeing then is that's the most obvious manifestation of a problem which is actually really complicated and difficult. And it's always easier to sort of in any one moment in time when you're trying to improve something to kind of play the man or the woman rather than the ball. And it seems to me that that's quite often we get stuck in that loop of management blaming clinicians probably blaming management, when actually neither of those things are to blame as such. And in fact, the whole concept of blame is probably the wrong approach. And I suppose where that takes me then is into some of what I wanted to say, which is I think I see the whole challenge of how you improve productivity as being very behavioural and very much about people and about organisations and the dynamics that exist within them. And I think it was interesting listening to Bart talking about the 5 things about digital skills, management, leadership, communications, and mobilising finance. I can absolutely see all of those being important. I think what I would tend to do, though, is say it comes down principally to two sides of the same. Productivity is two sides. Is on the one hand, you've got leadership and management on one side of the coin. On the other side of the coin, you've got technology. And it's a question of getting that right. But you have to recognise that the two sides of the same coin. And under the leadership and management side, it's not just about leadership and management in the conventional terms. It's about creating the conditions for change to happen. So I suppose as I think about the challenge you're engaging in, where do I then go in terms of areas that come to mind that might be I think probably are important, is first of all almost thinking about how can you create the conditions and build the capability to change, almost as a first point, because it must be so easy to look at all the data and say this trust is more efficient than that trust, and that unit is doing more hernia operations than that unit, and this and all those numbers must be sort of very tempting to jump onto those and say, so we just need to get everybody up to the top quartile. But of course that's a recipe for everyone, all the players, to say, yeah, but it's not like that in our region, or this is all the reasons why we can't do it. It's almost using data as a cudgel for change rather than a sort of beacon that helps people to see where the opportunity is. So there's something about developing the conditions and building the capability and using data, because I'm very much a believer in doing so, but using it in a sensitive way, which is all about geared towards bringing people with us on this journey rather than beating them up and making them feel inadequate because they haven't achieved something to start with. I also think it's very, very important to choose where to focus on. And I imagine this whole question of systems, health systems, is hugely important. I mean, my limited experiences, so I have a friend who's a palliative care nurse, and I was chatting to her the other day. Incredibly difficult job. And she was talking about community-based care and about hospital-based care or indeed hospice-based care. And the difference is that, a palliative care nurse in the community, I'm going to get these numbers wrong, but let's say they're looking after 20 patients at any one time. And there's no one else to look after those patients. And if you as a palliative care nurse really care about looking after your patients. And so if you've got a more complicated one that's taking twice the time, you can't say, well, I'm going to be more productive by halving the time there. And you've sort of got to get around all the 20, because if you don't, somebody's going to be in agony potentially. And so the pressure on those people is enormous. And of course, sometimes that leads to burnout. And then you end up with fewer palliative care nurses in the team than you should have. And then, of course, they have to take on 30 patients. And before you know it, you start having sickness issues because people can't cope. And so, there's something in the systems of care. And then there's also something about the handoff between hospitals and then into community care. Again, this is not my area of expertise, but I guess I'm just wanting to really acknowledge how important that must be to think about carefully about how that works. I also think Bart made a good point about mobilising finance, and I think there must be something within this world of how you tackle productivity in the NHS about give and take. Lots of people are worried about how much money we're spending on healthcare and how much money we're probably likely to spend on healthcare and whether that is affordable. And so, of course, there is a real interest in how can we become more productive with a view to saving money. But I can also imagine that in order to save money sustainably, we actually have to spend some money in some places. We've got to get the money into the right places in order to create the right systems such that actually sustainable and durable savings are possible and productivity improvements are possible. Because currently they're not, and my little example of palliative care is perhaps one of those. I also think it must be very important to be aware of what could pitch this all in the wrong direction. So there must be such a tempting thing for people from a long way away looking at this picture, analysing it and seeing all the evident problems that exist that are well furnished with all the data, then concluding that all we need to do is sort of move the bottom quartile to the middle or to the top, and then everything will be fine. But of course, that runs the risk of what I've already mentioned, which is that you can disengage the people you need to come on the journey with you very quickly in doing that. So I just think there has to be real care in terms of how some of the conventional mechanisms for productivity are then used. And I think the final thing I'll say is that I'm very conscious in sort of espousing something which is more bottom up and more people led and more about recognizing those systems, that somebody from the top down will say, yeah, but oh my goodness, is this going to lead us to lots of little bits of things going on? And I'm not going, and they might all be good things to do, but I'm not going to achieve the transformation that I know must be accomplished. And all I would say in my experience from a business context, and I can expand on this if it's interesting, is a decision to work from the bottom up, as long as it is done in a thoughtful and strategic way, is absolutely consistent with achieving lasting and durable transformational change. In fact, probably it's one of, not necessarily the only way, but in the context of something as important and as difficult as the NHS, it probably is the only way to achieve transformational change.
Brilliant. Well, that's a really interesting and actually probably quite a challenging place for us to start the conversation, because there are a lot of people in the system who I think have a mental model of top-down change. We'll set these targets, or we'll set these financial incentives, or we'll limit the budgets in some way, or we'll have more regulations or more expectations or more measurement or whatever it is. And that's how we get this system to move. So let me challenge you on that a little bit, Charlie, and kind of what I'm looking for is for you to kind of maybe paint a picture of, if you go for more bottom-up change, I can totally understand that that brings the staff along. You probably get better ideas. You get more local solutions that are probably better than top-down solutions. But how do you keep the pace? How do you then satisfy your stakeholders who want results yesterday and not in 10 years' time?
Yeah, and I think those are great challenges, and I wouldn't pretend that it's easy to square that circle. And I think that
is that where leadership comes in. Is that the job of the leaders to? I
think it is the job of the leaders to explain. I mean, I think dwelling in the problem, recognizing, it's why I mean, again, imperfectly, but it's why I talked about the nature of the problem we're facing. I think it's really important to dwell in that, because it is from that you then, I think, reasonably can say, so quick fixes are not viable, because we would have found them if they were. So there isn't really an alternative other than going through this approach, and then recognizing that we can't just sort of hope for 10 years where we do lots of little bits and pieces and then see whether it works out. We can't afford to do that. So I do think there has to be some meeting in the middle. So while I'm advocating for bottom up, I'm not saying, you know, I think this is, I guess, what I said about, you know, choosing systems, health systems, if that's the right words, I'm not sure, but choosing health systems which are sufficiently complete, not totally complete, but sufficiently complete, and then looking at those to say what opportunity is there, and what do you see from the data that says there's probably is quite a lot of opportunity if we could change the system on a more holistic basis to achieve much better outcomes. And then rather than then sort of saying to the people at the examples where the productivity is weaker, you know, all you need to do is this, what you then say is, we're going to work with you to change your system together with you to achieve what we believe is possible. And by the way, here's some interesting examples over here. It's a different pitch than sort of beating people up with benchmarking. And maybe through things like that, you can find enough. You can find enough critical mass in enough big enough examples to sort of convince senior leaders and policy makers that this is what they actually need to really support and go for. And then I think showing, I mean, the other thing which is fantastic is keeping people engaged is showing progress. I mean, I think it's always a bad idea if you sort of have to wait 10 years to know whether you're succeeding. You really need to figure out how can you start showing progress, and therefore getting the measurements right early on. Mm-hmm. And even if you've got a lower quartile performer, if that's getting better at 20% a year, yeah, that's really, or even in 3 months, it's improved by 10% in 3 months. It's that momentum which actually is usually critical to maintaining support.
Really interesting about.
Yeah, and if I may add to this, I mean, as I said, productivity is about change, and change is always around frictions. You can't have change if you're not willing to have some frictions in the organization. And if you think about an organizational pyramid, you got the top that sets the purpose, that sets the mission and the vision, and that needs to be very clear. You can't make an organization productive if the leadership at the top of the organization is not the ambassador of it. But you also have the bottom up that sort of needs to begin to see, how do we actually implement this in practice? Are we actually being listened to in this process? And that means that the friction ends up in the middle. It also identifies who in the leadership is quite often critical to this change, and that is quite often the middle management part of the organization, because that's the bit that has to listen to the leaders, try to translate that vision into practical implementation, but also listen to the people actually out there on the ground doing the work and try to translate that into where the organization needs to move forward. And then these 5 drivers of productivity come into view, right? It was interesting that Charlie was mentioning that, you know, of the 5, he sort of would start with leadership and management and technology. But then in his explanation, he picked up on all three others. Talk about, but we need to have skilled workforce. We definitely need to communicate it in order to bring people along. And we need to allocate finance, which quite often is not necessarily more finance, but putting the finance in the right place and at the right time. So if you want to make the NHS more productive, you have to accept that it's going to be difficult and that there will be tensions and frictions in order to get there. For that, you need purpose. But for that, you also need to have this bottom-up process of people who feel that they're part of that change process.
But you talk a lot about those 5 things coming together. So not one of them is going to solve the problem. You need them to be put together almost like as a package. Whose job do you see that in just any organization? Is it the CEO who orchestrates it all, or is it the top team together? Or is that also something that needs to be a little bit more bottom-up?
Well, the vision and the leadership, of course, sits to a large extent at the top. But again, we can see that from many types of organizations where you got a very visionary leader. And when the visionary leader goes away, the organization falls apart. And it basically means that that person hasn't succeeded to pull the rest of the organization along. So it really is then the key aspect of leadership is to begin to see, are there people in the organization who are carrying the message? And are those people in the organization, which quite often again is middle management, are they actually able to translate the needs and the requirements of people who actually do the work on the shop floor to see that they're being heard and listened to, and that I also can see, visible improvement in the processes that are taking place. So I don't think there's not one person in the organization responsible for this. Productivity is very much a collaborative process. In business organizations, yes, you think about the CEO, you think about the CFO, obviously, but you also think about the operations officer, about the CHRO, who's becoming much more important in all this aspect, and even about the marketing and communication manager.
Really interesting. So I have one other kind of challenge question to you, because one of the things we're going to want to try and understand, almost like, what are some of the leading indicators, or what are some of the things you could do first in order to create a bit of space for what is a very challenging transformation? And the message that I've heard a lot is it's around staff engagement, that there is a lot of good ideas, very well-meaning people, very smart people, but they're just kind of struggling with the weight of the system. And so I wanted to test a hypothesis, and you can agree or disagree, that if the first thing you started measuring was in fact staff engagement, and you said, well, your number one starting point is you want to improve that before you can improve anything else, could that work?
I think it's very important, and I think that it's, again, I'm going to really overuse my very limited exposure to this world, but again, I have heard people say in NHS they were so frustrated with the thing, you've got to let the system break so that it's so obvious that we need to fix it that we then start fixing it. Yeah, and I think I mean that again, I'm not saying that's universally the case in everywhere, but I think there's an element there which is one thing that does strike me is you've got this amazing intention. The intent of the people working in the NHS is generally speaking very good, and yet somehow people end up getting into a position where they feel powerless in delivery. And so I think that therefore there's something in your point about if you had a team who felt empowered, and therefore you could measure that partly through that would probably be a very strong indicator of the likelihood of succeeding, or at least if you could get a team who moved from feeling not empowered to feeling empowered, or started to move in that direction, that would probably be a very helpful indicator of the likelihood of progress.
Interesting. Bart, do you have any?
Yeah, I think that
also, because you mentioned well-being being a critical part of the whole human capital.
So if you start this change process, if there's a clear narrative, which I think we all agree on is so important, what's the North Star that we're after? How are we going to create those better outcomes, and what does it mean for resources? If you explain that clearly, you see staff engagement going up because people see, oh, this makes sense. But then the journey begins, and then, we have to prioritize, and prioritize means deprioritizing. We also have to agree and say, well, there may be things that are important, but we don't do right now. There's this great theory, it's called the bottleneck theory. Think of the system as a pipeline, and the pipeline has bottlenecks. Well, you need to start with the narrowest bottleneck, because you can start working on other bottlenecks, but, it won't flow through the system. you need to explain why that is the narrow bottleneck. You need to get others to say, but I got my bottleneck, to say, well, hold on a minute, let's do this one first, because your bottleneck will get much easier result if we deal with that one. So it's that continuous process that needs to happen. That quite often falls apart. And to me, that comes to good leadership. Can you keep that narrative going in order to keep people engaged? Or, sometimes under pressure of the markets, or under pressure of the shareholders, the direction changes again. And that's the best way to disengage people, because they thought they were on the change process and then it's not going to get anywhere. So that's, I think, where leadership comes in so important, is consistency, trying to sort of explain continuously to the people what is this journey that we're going. And sometimes we need to take a slightly different direction, but again, you have to think about how you take people along in that direction.
Great. Very interesting. We do have some questions online. So the first one is on innovation, and Charlie, you already alluded to this, that in the healthcare sector in particular, innovation often increases demand and costs more money, because suddenly we have an expanded range of possible ways in which we could improve people's health, and all of that costs money. So how could we actually, what are some of the things we could do to set some boundaries for this, or set some direction for the innovation in a way that actually improves productivity, as in outcomes per the amount of money spent?
Yeah, I mean, I feel like I keep pleading the fifth on sort of ignorance on this a bit.
Well, you can take an example from your businesses that you've worked in, because I'm sure it's the same. Engineers and creative people come up with millions of ideas, and they all say, we could do all this amazing stuff if only you give us some budget.
Yeah. I suppose I think there is a thing about the way that innovation drives demand. And so, people who are working in the NHS, and who obviously want to have access to the best technological equipment or processes or approaches to improve outcomes, often which will cost money and often which will increase demand, means that you're sort of running up a down escalator potentially in terms of how it must feel occasionally. So I think there's this issue. There's probably something about, again, within a wider policy context as well, about this is the sensitive territory, but what should the NHS pay for? And is there some conversation, parts of creating the conditions for us to improve productivity? It may require us to be a bit clearer about what the NHS is and is going to do and cannot do in order to achieve some kind of sustainable level of overall performance. That's well beyond my pay grade, frankly, in terms of sort of opining on it. But I can see that that's probably quite an important factor that might need to be included within any kind of choice that's made. I'm going to try and identify systems of care that could be improved dramatically. I think in terms of how innovation could work, I mean, one thing I've seen in my time, I mean, the example that Tara and I have talked about in other occasions is the way that the supply chain technology transformed the way that retail operates. Was extraordinary and fascinating, and I haven't got time, and you probably wouldn't be fascinated as I am to hear all about it. But I think just pulling out a few instances, I mean, it's not like somebody thinks on day one, there's a magic solution, and all I need to do is put the money in to create it, and then when you get, then it sort of appears. Actually, what happens is you recognise that probably technology has advanced to a point where we could develop a very different system of delivery. And actually and we should start doing that within the existing processes and the existing infrastructure. But then there does come a point when you recognise that what you need is you reach the limits of what you can achieve there, because the design and the sort of the legacy stuff is getting in the way. So you need to move to a new infrastructure to really start capitalising on that. And then when you get into that infrastructure, what you then also find is that the potential for incremental improvement within that infrastructure is often way, way greater than you think. And I think, in the context of supply chains, we at John Lewis, we had very steam-driven old supply chain operations, warehouses with people pushing carts around them and doing things in a very hydraulic way. And over the course of about 15 years, we moved to one of the most advanced facilities anywhere in the world. Now, one thing I should say on the point about leadership is that whole transition was led by an absolutely outstanding leader, a man called Dino Rokos, who joined the John Lewis Partnership as a Saturday partner in Peter Jones when he was 16, and was a brilliant people leader. And he took not only did he lead the technological transformation, but he led the people transformation, including the really difficult conversations with people about the fact we're going to have to shut this site, and that does mean that your jobs are redundant. And what we want to do is try and encourage people who can to move to the new site, but not everyone could do that. Again, I could go on, but innovation is generally a really good thing, and it can provide power, extraordinary changes in the capacity and capability of an organisation.
Thank you. Bart.
Yeah, I think a critical element about innovation is that it always has to come together with another key asset of an organization, and that's being a learning organization. That sounds obvious. Of course, if you want to innovate, you want to learn, but having a learning culture in an organization is really something that has major implications, because it means that you are willing as an organization to experiment, that you're willing to try things out. And it goes a little bit against what I said earlier about prioritization. So here's the friction. You want to prioritize, but on the other hand, you also need to look at opportunities, but it also needs you to have to be very disciplined as a learning organization about stopping an innovation if it doesn't work. You have to look for, Charlie was making the point on the importance of data. You have to collect data about innovation that you're trying out. You have to create a little bit of space for experiments, but you also have to be willing on the basis of the data to actually let it go. And I think a lot of organizations in the private sector, but certainly in the public sector, struggle with that, to be a true learning organization and to willing to take some risks and to let things go. Failure is not usually something that is very much appreciated, certainly not in an organization with a lot of public accountability like the NHS. So I think building that kind of learning organization and a learning sector is a key element in order to make innovation successful.
Mm-hmm. That's both of those perspectives really interesting. And Charlie, I was particularly struck by the fact that even if you have a new and shiny and technologically advanced system, there's always opportunity there too to innovate. And so, Bart, what you're saying, you need to continue to learn, you need to continue to look out for the opportunities. I guess the challenge is, how do you create the space for people to do that if they are at the same time incredibly busy just looking after patients? But what I'm liking about this conversation is you're being very clear. There are always going to be frictions. It is never going to be a magic bullet. It isn't easy, and therefore you need some deliberate choices at the top, and then kind of empowering system to deliver them. And of course you need to build in measurement, and you need to manage the system over time. But if you're too impatient, then you're probably going to shoot yourself in the foot, because you're just not going to give the system enough time to get to the next place. There are some interesting other questions here about capital, because both in the kind of broader economy, but also, by the way, Charlie, in your example of the warehouses and IT systems, capital can liberate people to be more productive. They can see more patients, or they can provide better diagnostics, or a more targeted intervention. But it is something that we're chronically short of. And it's not just the amount of money is not necessarily what it needs to be. It's hard for systems to allocate capital properly, to decide where to put it, because obviously everybody will be shouting and saying, I need it in my part. So maybe I'll start with you, Bart. You talked about bottlenecks. And so instinctively it would make sense you spend the money where the bottleneck is to start with, in order to create this bit of capacity in that part of the system, and the bottlenecks more somewhere else. But how does a leadership team in an organization identify those bottlenecks?
Yeah, I'm actually trying to reflect a little bit. Maybe this is a question back to you.
Fine.
On why is it so hard to allocate capital?
Mm-hmm.
Why do we find it easier to allocate current resources to increase staff pay? Not that is easy, to be clear, but once that decision is taken, it's kind of taken. Why is it so hard to make these capital decisions? Is that because the return on that capital will take significant amount of time before it will pay back? Well, if that's the case, the key issue in leadership is to show what happens if you don't. Because as I said in my opening comment, I think to me, the main problem in the UK, and I think that certainly translates to the NHS as well, is just a significant undercapitalization of the sector. And then we can spend on current expenses and current resources as we want. But if you don't have a good capital asset base, whether there are buildings or equipment or whatever, on the base of which you can actually begin to make these investments, it's going to be very hard. And particularly in this time of AI and artificial intelligence, where it hasn't been mentioned yet, huge potential in the sector. But with a low capital base, it will be quite hard to actually bring these kind of investments to fruition. So maybe it's a little bit a question to you, because I don't have a real answer why that would be so much harder in the public sector than in the private sector. Because even in the private sector, we don't necessarily know what the returns on that capital investment are going to be in 5 or 10 years' time before it's going to pay off. Is it because of higher public accountability? Is it because there are more decision makers in the mix than is the case in a private sector organization? I don't know.
Well, honestly, you wanted to come in, so why don't you say what you think on this question?
Well, I think Bart's comments have picked up a very, very important question, which people don't ask often enough, which is, what is the mechanism that stops the NHS spending adequate amounts of capital? Everybody knows they don't spend enough, but it's quite complicated and nobody really wants to get underneath it. I have at least one theory, which I think explains quite a lot of it, which is the fact that we use the capital budget in the NHS by deliberate choice of the NHS leadership as a contingency fund to bail out people who overspend everywhere else. And that steals a significant proportion of the allocated capital budget, which is already inadequate almost every year. So there's a mechanism, and I think the mechanism goes deeper than that. But that's what needs to be investigated, because there's no point saying give the NHS more capital if the mechanism is still broken and we put it in the wrong place.
Yes, interesting. So there are some very idiosyncratic ways in which the financing side is managed that causes money to be misallocated. Yes, Anita.
Can I ask a question to both Bart and Charlie on the back of this? Because Bart, in your opening remarks, you talked about confused governance. And one of the things that's coming up over and over again with the Productivity Commission is we have simultaneously a very highly centralised system, and then also actually quite a chaotic, complex network locally. And actually, I think no one that we've spoken to says the answer is either completely centralised or just, completely decentralised. They're talking about how you combine those and think through much more carefully where you make decisions, who you empower over what. But part of, I think then, and I was wondering if this is in the NHS, it feels like very confused accountabilities and governance, this very strange mix of centralised and localised, makes it very hard to do the act of stewardship that capital often is, which is, and especially then when you combine the fact that we've got managerial turnover, which makes football clubs look like secure career options. You actually, weirdly, in a system that is over 75 years old, we're sort of, managers often, and leadership is optimising for the next 2 weeks if you're kind of lucky. So the stewardship function isn't very strong. And then who actually really is accountable? Who would you phone up, about the fact that this health system in a place is woefully undercapitalised? Actually there is no one. It's not clear who you'd hold to account for that. But you discuss, and I wanted to ask, I guess, John Lewis in particular has a particular model of that kind of stewardship, some of the leadership qualities around that. But Bart, you talked about the fact that actually across the economy, there's kind of quite confused governance is quite an issue. And I don't know if that plays out particularly in some of these more longer term investments elsewhere, and whether that therefore would be something we should think about.
I mentioned it because we're obviously, when it comes to governance, not in a good place in the UK. We're on the one hand, as I said, the most centralised economy within the OECD, as my colleague Philip McCann keeps emphasising. That doesn't look like a good place. On the other hand, we have this hugely fragmented, unclear, untransparent kind of local kind of framework. So we do mention it's important. At the same time, I want to be careful and not say, well, if we get that right, we'll all be fine. For 2 reasons. I don't think that's true. But secondly, it will be a while before we get that right. And that will be a lifetime for all of us. So we have to work with what we have. And in that sense, I have to say that, the move in the past what is it, 5-10 years towards combined authorities, to at least scaling up local authorities to a level that you can begin to make strategic investments is going to be very important. It's not ideal, but I think it's the best we can work with right now. And I think the most important message for any public sector, but certainly also for the NHS, to see to what extent can we align ourselves organizationally to that concept. Because it's the real problem here is that we quite often geographically working in different places, it's just making it all so hard. If we could just organize the sector in a way that it gets a bit more aligned, that won't get us in an ideal place, but probably in a better place. So I think that's what we probably have to look for a little bit, because then capital decisions become a little bit more important and become more stable. Instead of saying we need a complete overhaul of the governance system, well, then we'll be busy forever. And in the meantime, we'll still fall further behind.
Charlie?
I think, I suppose the first thing I'd say is if you really have a situation where the leadership is only able to focus on getting through the next 2 weeks and you're getting a lot of churn in the leadership, then it's, I think, pretty obvious you're not going to improve productivity.
Yeah.
That's kind of, I also think the point about, why is the system highly centralized? I suspect it isn't because the people at the centre are absolute out and out control freaks. I suspect it's because the system is so complex that they just can't take the risk of being anything other than highly centralized because they've got nothing to devolve to, or not enough to devolve to. Yeah. So I think, while I think it's quite an awkward and a difficult thing to do, I think it seems to me there isn't a way. We're not going to improve the productivity of the NHS or parts of the NHS unless we create the space and the conditions where that is a viable prospect. And so, I guess I would think, identifying systems of care that offer potential for improvement, identifying leadership and making sure that leadership is brought into leading the charge and has the latitude and the support to do so. And then there's an ambition wrapped around that. Those have to be in place. And if you don't,
in that context, when you say systems of care, do you mean units, so like a hospital or local?
Well, I suppose I'm thinking, I don't understand, I keep saying, the detailed context, but I do appreciate that the efficiency of a hospital. If you just look at a hospital and you don't take account of community care, you have got some real challenges in terms of how you so there's a system of care. Yes. What I don't know is whether the best way to draw a line around the system is in a region, or it's in a therapeutic pathway, or it's for a particular cohort. I'm not sure.
I don't think anyone knows.
Others would be better at that.
And honestly,
I think you have to define what those are.
And this reminds me of an important concept, I think, in complex corporations. You have the exact same issues around, should we centralize or decentralize? Should we split the business up by function or by region or by product line or by segment or by whatever? And from memory, when it comes down to it, the theory suggests that you should do all of the above but in a sequence. So you do something in order to change the previous regime, not because there's something you're moving to is ideal or will be sustainable, but because that change forces you to look through a new lens that you need in that particular case. You continue that for several years in order to get the real efficiencies out of it, recognizing there was never the landing place. There's always the next thing you need to do. Comes back to Bart, your point about learning organisation. Yes, please.
Hello. So I'm Helen. I'm Chief Executive of a charity called Patient Safety Learning. So obviously looking at things through a patient safety lens. But picking up Charlie's point about systems, we know that transitions of care either within an organisation or across organisations are where there are significant patient safety risks and there's significant avoidable harm, the scale of which has not really reduced in the last 20 years. So we're not doing something right here. And I wonder if there's some sort of reflections on that. We're talking about capital. We invest in capital by organisation and not by system. So we've put little barriers. So if you look at interoperability issues with technology, we've got primary care not able to speak to secondary care because the capital budgets and the decisions for those are individual organisations, not system. So it is something possibly about looking at productivity, not just within an individual organisation, but looking at your point, systems of care, pathways, whatever. And maybe there's an opportunity then, if we get to the transformative agenda of the 10-year plan to move from hospital to community or neighbourhood-based care, that we're looking at how we make those investment decisions differently. So more of a reflection for comment rather than the question, I suspect.
But I think you highlight some of the barriers you see. So I mean, if budgets are allocated and capital is allocated in a very unit basis, but not across systems, then you're going to have competition between the leaders of those units who are going to want to do everything they possibly can to hold on to everything they've got and get more, hopefully, which is then at the expense of somebody else. So I think these are, but again, this is classic stuff that happens in every organisation. It's all over the place. I think on the allocation of capital, just want to sort of add on that. I think one of the reasons it's difficult is because capital is always limited, always. Even in our dream scenario, it will never be quite enough. But also because basically the people who've already got it tend to hold on to it very firmly. So actually, what you end up having a debate about is not about the total budget. You end up having a debate about the extra bit on top, without looking at the bit you've already committed and the reallocation of the stuff that was committed. So I find in businesses I'm involved with, I say, look, why are we talking about the increase in pay? Why aren't we looking at the total salary budget and saying where could we make efficiencies within that total salary? I cannot believe there's not opportunity to drive some efficiency in the total budget. It's not that we shouldn't be just debating the extra amount we're putting on top of last year's amount, and that's why it's difficult. But again, really, and it requires strong strategic leadership to orchestrate the processes such that those things happen.
And willingness to deprioritize, right?
Yeah.
Where you say you have to stop a few things in order to make other things happen. Which I had a conversation 2 weeks ago with people from the sector here, and I made the same point about prioritization. And somebody came back and said, "Well, you're clearly not working in the healthcare sector. We can't deprioritize. I can't deprioritize patient care. I can't deprioritize this, or I can't and I totally get that. But I think that's now really up to the leadership to begin to identify where can we make changes that are not going to be harmful or too harmful to the people we're trying to serve.
Mm-hmm. Well, that's probably quite a good place to start bringing this all together and just say some final remarks. So first of all, I think we are going to take on this challenge of how do you create a system in which you can prioritize where there isn't inherently going to be agreement on what can be deprioritized. Everybody wants more care and better care and faster and sooner. But somebody somewhere will need to have the courage to say no to some of those people in order to actually get the overall system to deliver better. And the points that you've made throughout about leadership and management, a lot of that rests with being just quite courageous and sticking to it. So not being persuaded every day that there's a new problem to be solved, but actually setting out a longer term trajectory and then having the patience to deliver against it, even though people will still be unhappy with what you're doing. But as long as you know what the North Star is and you can measure it and show some success, it's very much a doable challenge. I wanted to thank, first of all, the team for organizing the event. Obviously, thank Bart and Charlie enormously for coming today, sharing your thoughts, your contributions and your insights, which have been really invaluable in us thinking about what is a very complex but not a new question in a lot of ways. I wanted to thank all of you for joining us and for your incredibly interesting and thoughtful questions. We will continue to explore what the answers might be. And then finally, just to say, there will be a recording available on YouTube, which will be emailed round. So if you know of people who wanted to join and couldn't, they will be able to watch it afterwards. And do think about joining the next evidence event on the 25th of March, which will then look at good practice inside the NHS, what we can learn from that, and how could we maybe diffuse it faster to other bits of it. So thank you all for joining.